In this video, we will be describing cataract surgery with coexisting corneal degeneration. Corneal degeneration is an all-inclusive term encompassing a broad spectrum of conditions that may result from physiological changes secondary to aging. They may be the sequelae of environmental insults, or they may present as ocular manifestations of systemic diseases or long-standing local inflammations. Corneal degenerations may be classified based upon the etiology, the location, or upon the corneal layer involvement. They may be age-related or pathological, they may be centrally located or peripheral, and based on the layer of involvement, the degeneration may have epithelial changes, stromal or endothelial changes. Our discussion will include cataract surgery in the setting of Terrien's marginal degeneration, Salzman nodular degeneration. Terrien's marginal degeneration is a slowly progressive peripheral ectatic corneal disorder that more commonly involves the superior cornea and is characterized by the development of discrete subepithelial opacities in the peripheral cornea that progress circumferentially, resulting in peripheral furrow formation, corneal ectasia, vascularization, and lipid deposition. Two types have been documented. The first, typically non-inflammatory one, occurs in the older population and is slowly progressive. The second, more inflammatory type occurs in a younger subset of patients and occurs in the second to third decade of life. Vision loss is usually from high degree of against the rule or oblique astigmatism, and corneal topography reveals flattening of the peripheral thinned cornea with steepening of the corneal surface approximately 90 degrees away from the midpoint. Perforation is rare but may occur spontaneously or as a sequelae to trauma.
Corneal surgery in TMD is indicated when perforation is imminent due to progressive thinning
or when the astigmatism significantly limits the visual acuity. Crescent-shaped lamellar and full-thickness corneoscleral patch grafts have been reported to arrest the progression of severe against-the-rule astigmatism. Annular lamellar keratoplasty grafts may be required in severe cases of 360 degrees marginal degeneration. However, a critical point is to ensure that the corneal findings should be relatively stable. Any surgical planning can be quickly invalidated if the degeneration is actively progressing. As a prototype of this discussion, we will describe cataract surgery in an elderly female patient who presented with the classical features of Terrien's marginal degeneration, presenting with peripheral thinning. The primary concern in these cases is corneal thinning, as intraoperative perforation during phacoemulsification has been described, although it is a rare occurrence. Pentacam tomographic maps confirmed the clinical features, depicting an against-the-rule astigmatism of approximately 3.5 diameters, the relative Pachy map showing a supratemporal thinning, and the Pachy progression map showed a dipping at the 2 mm zone with an upshoot again at the 5 mm zone. Specular microscopic examination revealed a normal endothelium with a good endothelial cell count and relatively normal central corneal thickness. Preoperative planning included accurate digital biometry readings using the Pentacam keratometry values. Performing successful phacoemulsification surgery amidst the variables of corneal thinning and scarring rests on the maintenance of optimal fluidics parameters. By presetting low flow and low pressure parameters, cautious phacoemulsification is performed. Scleral tunnel incisions are usually preferred, with the exception, as in this case, where significant peripheral thinning necessitated a limbal incision to afford good maneuverability of the phacoprobe, paying special attention to achieving gradual occlusion breaks during chopping, preventing incisional distortion, and maintaining good anterior chamber stability with minimal surge. Another preferable technique for providing superior surgical control is to use bimanual irrigation aspiration for cortical cleanup. At the conclusion of surgery, a 3-piece acrylic IOL is implanted into the bag and thorough viscoelastic removal is done. Postoperatively, visual improvement was gratifying with minimal astigmatism, white pseudophakia, and no worsening of the coexisting corneal degeneration. Salzman nodular degeneration is a rare, non-inflammatory, slowly progressive idiopathic degenerative disease of the cornea that is characterized by bluish or whitish-gray corneal opacities occurring either as discrete nodules or as extensive ring-like peripheral opacities occasionally associated with fine subepithelial neovascularization. The clinical presentation of Salzman degeneration is variable, and the nodules can be either asymptomatic or cause foreign body sensation, blurred vision, glare, photophobia, or epiphora. Risk factors for developing the degeneration include prior history of ocular surgery and several ocular surface diseases, including meibomian gland dysfunction, chronic blepharitis, trichiasis, trachoma, previous ocular trauma, Thygesson's punctate keratitis, vernal keratitis, filamentary keratitis, flectennular keratitis, or epithelial basement membrane dystrophy. Cataract with Salzman nodular degeneration poses several unique challenges which can majorly alter the outcome of cataract surgery. Firstly, Salzman is frequently associated with dry eye and causes irregularities in the corneal surface that decreases the best corrected visual acuity. Secondly, the uneven ocular surface lends to significant irregular astigmatism on corneal topography, contributing to challenges in capturing digital biometry readings. Removal of Salzman nodules should be considered prior to cataract surgery, as even peripheral nodules can cause central corneal flattening and astigmatism. Therefore, patients may need to be counseled regarding the possibility of sequential surgery. Despite complete removal of Salzman nodules, corneas may retain some irregularity that may reduce contrast. This would limit the success with a multifocal lens implant, so monofocal intraocular lenses are preferable. Conservative management may be initiated with ocular lubrication, warm compresses, prescribing a lid hygiene regimen, and those with underlying inflammation may benefit from a short course of topical corticosteroid or oral doxycycline. Cyclosporin drops, autologous serum, temporary or permanent punctal plugs may also provide symptomatic relief. Surgical intervention is recommended in individuals with symptomatic nodules, nodules located in the central visual axis, and nodules which persist after failed medical therapy. Superficial keratectomy with adjunctive procedures for the removal of nodules can restore the original corneal contour and reverse the hyperopic shift and astigmatism caused by the degeneration. Superficial keratectomy with or without for manual excision of nodules is often the procedure of choice, with alcohol being used to loosen the epithelium prior to nodule removal. Amniotic membrane transplantation has been used as an adjunct after superficial keratectomy to help prevent inflammation, scarring, and vascularization, promoting early visual recovery by creating a smooth corneal surface in the immediate post-op period. However, if significant corneal haze remains after superficial keratectomy, phototherapeutic keratectomy can be performed and is indicated in cases where superficial keratectomy alone may lead to the formation of deep defects within the pomin's stroma, or in cases where complete mechanical removal of nodules is difficult. Mitomycin C can be applied intraoperatively after superficial keratectomy to target the fibroblasts within the stroma and decrease the frequency of recurrence. Keratoplasty is rarely indicated for the treatment of Salzman nodular degeneration and is only indicated where lesions are extending deep into the stroma. Even in these cases, however, anterior lamellar keratoplasty is typically sufficient because the endothelium is often intact and healthy. For individuals who fail conservative management but are not surgical candidates, the prosthetic replacement of the ocular surface ecosystem has been successfully used. Patients may present with decreased visual acuity due to extensive Salzman nodular degeneration and moderate cataracts. Apart from the physical discomfort, removal of Salzman nodules should also be considered prior to cataract surgery, as even peripheral nodules can cause central corneal flattening. Once the leading edge is identified,
and be lifted by dissection using the hockey stick blade
and carefully peeled off in a curvilinear fashion without letting it affect the underlying corneal tissue. The approach is usually perpendicular to the limbus, removing the conjunctival adhesions to decrease the risk of recurrence. As an adjunctive procedure, 0.02% mitomycin C soaked sponges are placed on the corneal surface to contact areas vulnerable to vascularization and nodule formation for approximately 20 to 30 seconds. Thereafter, the surface is washed thoroughly, dried, and multilayered amniotic membrane is secured with the help of fibril glue and burr string sutures. Surgery is concluded by placing a bandage contact lens. Following superficial keratectomy, reliable keratometry and IOL power calculations were obtained, and the patient successfully underwent uneventful phacoemulsification cataract surgery. These cases highlight the importance of addressing the refractive sequelae of coexistent corneal degeneration when planning cataract surgery to ensure minimal postoperative astigmatism and achieve favorable outcomes.